Hello and welcome to today's Power of Knowing webinar, Celebrating Diversity in Hospice and Palliative Care. Understanding comes from knowing. Healthcare disparities exist for multiple reasons, including historical, cultural, and economic. While hospice and palliative care services are designed to meet the individual needs of our diverse community, many remain underserved. One way to reduce barriers to service is to better understand how caregivers can create more welcoming and safe experiences for those seeking care. And since understanding comes from knowing, this presentation will reveal some of the challenges various underserved communities have when seeking care. This free webinar series called The Power of Knowing was created by AuthoriCare Collective, which empowers people to be active participants in their care journey, enabling them to live on their own terms through personalized support for mind, body, and spirit. To get us started, please welcome our moderator, Risa Hanow. Risa serves as clinical and community educator at AuthoriCare Collective and is also a member of the Cone Health Ethics Committee. She's a licensed clinical social worker. Risa, I turn it over to you.
Thank you, Paul. It is my pleasure to introduce our panel for today. First, I would like to introduce Jacqueline Lopez Devine, or Jackie. Jackie holds a Master of Nursing and Health Policy certificate that she earned at University of Maryland School of Nursing in Baltimore. Jackie has a rich nursing career where she has worked in administration, quality improvement, and with multiple health systems. In 2006, she joined TrustBridge and has held many roles during her years at TrustBridge, but there have been some constants in her work. One is that she always views herself as a coach, a cheerleader, and a change agent, and always keeps her focus on ways to ensure the highest quality patient experience and outcomes. Welcome, Jackie. Mary Manley. Mary Manley is the Director of Growth and Provider Relations here at AuthoriCare Collective. Mary currently serves on the Board of Directors for the Elon University Anatomical Gifts Program, and she is also a member of the Diversity Advisory Council of the National Hospice and Palliative Care Organization. Mary has worked in the senior community for over 20 years, and she has been a staunch advocate for the disenfranchised, always working to ensure compassionate and quality care for seniors, and making sure that everyone has access to die with dignity and respect. Mary knows firsthand the value of advanced care planning and what excellence in end-of-life care means for patients and their families. And Sandy Chen Stokes. Sandy is a nurse and a volunteer. In her professional and volunteer roles, she has focused on end-of-life care, elder care, public health, mental health issues, all in the Chinese American community. Sandy has been recognized many, many times for her work. And one that I would like to mention is that in 2011, she was one of only 10 people in the nation to receive the AARP Inspire Award. Sandy is a member of the advisory board for the Chinese Health Initiative Project at El Camino Hospital in Mountain View, California, and she also serves as a member of the Diversity Advisory Council with Hospice and Palliative Care Organization. Welcome to each one of you. We are so pleased to have you. And as we begin our conversation, we want to recognize that November is Hospice and Palliative Care Month. And to that end, we want to focus on meeting you where you are. And a way for us to do that with our participants is to be able to have some polling questions. You'll see 2 questions come up on your screen, and we hope that you'll take a moment. The first question is, who is joining us? And you'll see it is multiple choice. You can choose all that apply to you. And then the second question is whether or not you identify as a member of a minority group. The polling is confidential, so please feel comfortable to respond, and we always appreciate getting to know a little bit about who is joining us in this virtual environment as we have our conversations. And we also know that so many of us fill so many roles at the same time. So thank you for taking a moment, and we will look at the results. We have really a very diverse group joining in terms of the minority, identifying as minorities. Everyone who responded does identify as a member of a minority group. And then who is joining us, we have a really good division of healthcare professionals and caregivers, those who serve minority group members and spiritual care guides and advocates. So thank you all for participating. That gives us a wonderful sense of who is joining us. And as we begin our conversation, please make use of the question and answer box, the Q&A box on the Zoom screen. Send a question at any time, and we will do our best to answer that during the time of the webinar. But to get us started, Jackie, I know that you are passionate about ensuring that anyone and everyone who could benefit from hospice or palliative services receive those services and receive them in a timely fashion. And so talk to us a little bit how you've taken that passion and you've put it into action for those in your community.
Thank you, Risa. And thank you to everybody. It's an honor to be here representing TrustBridge and representing the Latino Hispanic community as well. So the first thing is creating awareness in terms of what we do and the service that we do. There's so much misconceptions out there, in particular amongst, the Hispanic community, but really any group. So the first thing is creating awareness. And part of that is using my Hispanic, my Spanish language and going out and educating the community and finding staff that are also reflection of the community and that can go in and speak in Spanish and speak in the native tongue of those that we're trying to serve, so that we can meet the need. I mean, that's really, it's not a secret. We're seeing it more and more in the literature. The Centers for Medicare, basically, they're looking more at how we can create more health equity in terms of, with the different minorities. And one of the things that we are seeing is definitely it's important to have healthcare professionals that speak the native tongue. So for me, that was very important to get out there into the community and find where the underserved are in terms of those that speak Spanish. So one of the things that we've done as a group is find physician groups where, it's incredible to me how things have progressed. Physician groups that actually do teaching of their constituency, in their community. And they are now requesting for all types of diabetic teaching, all types of cardiac teaching, everything to be done also in Spanish. So creating an army of staff who can help, me and the team deliver that message. And then we always in that health message, we always talk about end-of-life care and hospice and palliative care, so that it becomes natural. This is a natural progression. Now, you talked about timely delivery of care. That's really, really important in the work that we do. We actually are very measured in how we deliver the care to everyone. We have goals in terms of making sure when someone refers somebody to hospice that we're there responding same day, in terms of just even making a connection. And so that becomes really important if you're talking about somebody that of the Hispanic community. You've got to find somebody that can speak Spanish. And it is a challenge more and more these days with staffing and how things are. But it is possible. We use things like the language line. We use things like, professional volunteers who have been trained. So it is possible. And the timeliness is an important part. And I would say to the community, it's important to know that the hospice that's serving you, uses measurement and data. And that is something that we do. We measure our response time. We measure how well we're meeting the needs of the community. We measure our groups, in terms of Hispanics. Actually, 7% of the patients that we serve are Hispanic, which is actually not reflective of the population. So I know we still have more work to do. I'm going to end it there, Risa, and see if I don't want to talk too much. So you're on mute.
Thank you. I appreciate that. Your message is one that is important for all of us to hear. The message of who it is that is providing care and knowing our communities and what groups are in our communities and being broad in that thought of thinking. Certainly the Hispanic community, also the LGBTQ community, the, different groups and all of those who are joining us who have identified as a minority group. We want to know who you are so that we can work to meet that need. So thank you. So Sandy, you certainly have done a tremendous amount of work in the Chinese American community. And I know focusing on education and access to services. And you are going to tell us about that work that you have done. And I hope that you will not only educate us on your work, but also help us to understand how what you've done might be transferable to other minority groups and so that we all can make use of some of this work that you have done and continue to do.
Sure. Thank you for inviting me to be this group. And I have to say that this year is my 40 years, going to be my 40 years as a nurse. 40 years ago, I was still on my rotation, become a nurse. So for all those 4 decades there, I can say one thing is, it is difficult to talk about end of life. Doesn't matter who you are, right? And then I truly believe that the best time to talk about end of life is before our patient or family member going to your facility, right? ER, ICU, so on and so forth. So that's the reason when 17 years ago, I decided to form this organization in the community, work with the group to start this so-called Chinese end-of-life movement, start from our healthy Chinese American here. So Paul, I think I'm ready to share the PowerPoint with everybody. So this is the Chinese American Coalition for Compassionate Care that we established back in 2005. Yeah. And we founded in California to address lack of linguistically and culturally appropriate information for the Chinese American community. This also still is the first and only coalition in the United States devoted to end-of-life care for Chinese community. Next. So thank you for Risa's good kind words, but yes, CACCC has been pretty successful doing our work. This long-term success for us come from our coalition model. So that's the one first thing I want to share with everybody. If you serve with different minority group or American in general, I believe a coalition model is one of the best I have experienced, because it brings professionals and community leaders together to collaborate and develop and share Chinese English end-of-life education and resources. Yeah. So ACP, Advanced Care Planning, is one of the most direct way to begin end-of-life outreach with any community. We believe that ACP in all other communities may bring family, friends to discuss, and then lead to complete a form called Advanced Healthcare Directive, right? But for Chinese community, it might be reversed because in Chinese culture, we believe in doing the things right way, right? Or to be a good citizen in the country. So we will follow the rule of the healthcare system. And then to introduce advanced directive, we look as a right thing to do. So we'll be able to start after the form, we start talk and we start think about the important things related to serious illness, even with a death and dying. So we also use the way CACCC is very famous to say that this is probably the ACP and the forms probably is the one of the best and last gift we can give to ourselves and our loved one. So that really bring particularly our seniors, yeah, I want to have that complete because I do want to give my loved one a gift that they don't fight each other with not knowing the decision I will make, but I never share. So so that's what I like to share with everybody. The coalition model, you can always go to our website and find the work we done. Okay, next, please. Here is the biggest challenge with our Chinese participant or community, always being to start to share the end-of-life concern and preference, either with our health providers or with our loved one, or even with ourselves, right? So this is all the materials we develop or translate to the middle one. You can see those look like a pokers. It is a poker, but it's a little bit different because each card has end-of-life related statement there. And it's English and Chinese. We made that as a 54 poker cards. With these cards, it really can help the Chinese American able to discuss end-of-life issue much more easier because it contains this statement that last time for us is not be able to think about those important issue there. It can remind us to also to help us to be aware the option we might not thinking about. So this card game are typically played as at a heart-to-heart cafe. We have 5 different ways to play the cards. And this cafe actually, we serve the tea and pastries. Right now, the COVID season, we use online as well. And then we help the participant able to have an environment safe enough to encourage them to discuss end-of-life issue. And all the cafe will facilitate by a trained facilitator. So all those materials are free to download or to request, except the card. They have some cost for that. Okay, next one. This is the, okay, got it. Okay, community event, the other one, last one. Okay, community event. This event, before the COVID, all the pictures are from previous COVID. Right now, we all doing that through the virtual. So you can see we went to different city, different states in New York, California, and also the international go to China, Taiwan. And then this is the key that we start education for our community. We believe that's how we spray the seed. By the time they are ready to facing the challenge, even their loved one or themselves, they already have an idea what's the important medical legal documentation for, and they might all already prepared for the hospital. Okay, next. Yeah, okay, this one. Okay, so we train volunteers, like you saw that earlier, for patient ambassador program, besides other hospice program. This is a ambassador program. You can see in the middle, it's a lady there, knock the door of the patient's room and bring the Chinese newspaper and visit every Chinese patient in the hospital. That particular hospital is the one down below on the right. It's a El Camino Hospital in Mountain View. We started that program 2014, work with the hospital to train volunteers, become their volunteers, called Chinese Ambassador Program. So, so far it's been many years. We do it once a year or sometimes twice a year. So we also go to nursing home and patients' home with their hospice and palliative care agency. Okay, next. Okay, so this is the ACP program that we provide, including the workshop to complete a form. We have a trained volunteers and health provider to help them. But before that, we normally start with ACP presentation. For people who we encourage people to have a speaker bureau. If you are thinking of to go out, reach with a certain community group, ethnic group, we will say build speaker bureaus. Because the speaker bureau able to reach out to everybody with the full of prepare of knowledge as a hospice and palliative care, and knowing how to talk to the different group, different generation, and how to work with them. That's very, very important. Okay, next. Oh, this is the one we did the Heart Cafe. We go to the different hospitals, senior center, church, and people's home. You can see the left side button. You can see the whole family and friends get together, have a tea and pastry, and we start to play the cards and share the information. I remember that's one lady who is the mother or mother-in-law of that host. Later on, the wife told the husband, say, this is the first time mom ever told me about anything related to the critical ill situation, what I want, what I don't want. And she was very clear, state that if situation happened in that point, please don't do any invasive so-called treatment, such as the tubing. I don't want any tubing. I don't want a CPR. So they really feel comfortable to share that among their senior parents, because otherwise they never dare to talk about that. So that's just one example. I think I'm getting closer to the end. Okay, that's it. So this is an example. Definitely it's not just only going to work for the Chinese community, any community that you can look into, and we are more than happy to share our experience. Thank you.
That's just so wonderful. I mean, putting, Jackie and Sandy as we think, again, broadly and diversely. So Mary, I know that not just professionally, but I know personally You are really very in tune to some of the barriers and also some of the myths that are out there in the African American community, but other communities, other minority groups, in terms of people perhaps being hesitant to utilize hospice services or palliative care services. And I wonder if you could talk to us about some of those barriers and some of those myths, and also some of the positive steps that are being made. Clearly, Jackie and Sandy are a part of that, and also at the national level, the work that's being done.
Absolutely. Thank you so much, Risa. And I am so grateful and honored to be a part of this distinguished panel. But yes, as a part of business development for ThoraCare Collective, a lot of what we do day in and day out is around education. And that's a never-ending process because there are so many misconceptions and so many barriers to patients accessing hospice care. And of course, as the U.S. population becomes more diverse, the need for culturally competent end-of-life care has never been greater. And so to put that into context, I think we should acknowledge that first, the population is aging, and the number of Americans age 65 and older is expected to double by the year 2060 to something like 98 million people, seniors. Our country is also becoming ethnically and racially diverse. We'll see a population explosion of Latinx older adults who will who will account for the largest percentage of older adults in the United States. And then we're also seeing an increase in LGBTQ seniors or older adults, or those who identify as LGBTQ. And so, of course, at the heart of hospice and palliative care is a holistic, individualized care model that does support the highest quality life possible for, whatever time a patient has left, wherever they live, whatever their disease state is. Our goal is to address patients' physical, emotional, social, and spiritual needs. We are here to support the entire person, the whole person. And I believe that most of us would agree that access to quality care at the end of life is a fundamental human right. But also at the end of life, many patients face significant barriers to accessing equitable care and are less likely to get the information that they need to make educated judgments about their care and to fully be empowered to have the death that they want to have at the end. And so to put this into even better perspective of where some of the disparities lie, in 2018, for example, Asian Americans, African Americans, and Hispanics represented only 20% of Medicare hospice patients, while the remaining 80% were Caucasian. And this is reported by the National Hospice and Palliative Care Organization. And even though African American patients, for example, are far more likely to die from complications related to cancer and heart disease, kidney disease, diabetes, we're 10 times less likely than white patients to access hospice at the end of life or within that last 6 months of life. And so a lot of the disparities that we see in care, the inequities that plague minority and underserved communities, these are things that they face for their entire lives. And so we're at a point now where, we really need to make some changes. Research has shown us that patients distrust the healthcare system. A lot of patients do, based upon a lifetime of experiences with provider bias, discrimination, hindered access. All of these things have led to the disparities that we're facing now and the things that we're trying to counter. And then we've got limited health literacy and a lack of knowledge of what the care options out there are. When providers are talking to patients, oftentimes they're speaking in terms that patients don't understand. We don't always understand the descriptions of treatments that the care team may use. And that does impair our ability to make informed decisions. And also providers have difficulty. So the difficulty doesn't only lie with patients, but oftentimes the difficulty lies with providers. They have a tough time oftentimes having those difficult conversations around death, or they talk too briefly or sometimes not at all about the illness trajectory and what the palliative care or end-of-life options are. And so this is especially true when communicating with individuals from diverse cultures and communities. All of these factors can result in increased confusion where individuals don't understand their providers and they feel that they don't have that alliance and can ask those hard questions. And plus, they oftentimes feel judged by their providers, where they are treated differently than their Caucasian counterparts. And so they're more reluctant, I should say, to ask questions and share their fears and concerns and hopes for their care. So within some cultures also, spiritual and religious beliefs present barriers, where in some communities, patients are, want to seek and procure treatment no matter what. They want to go for those aggressive treatments, although the aggressive treatments may not be effective and may even make the end of life, the quality at the end of life, not as desirable. And so at the end of the day, patients and often medical providers lack the knowledge and understanding of what the resources are that exist, what hospice services truly are, what they aren't, the value that the resources can bring to a life and to a family, and how to gain access. So patients and families are often forced to draw their own conclusions, and oftentimes those conclusions are based upon myths and not fact-based. And so I do want to share a few myths that we hear from time to time. Excuse me. One in particular, one of the myths that hospice should be called only in the last moments of life. And we in the hospice industry know that the earlier hospice is engaged, the better. And that there's so much that a patient can gain from engaging hospice early on in terms of pain and symptom management. And so we work diligently day in and day out to encourage providers and to encourage families to engage with us and allow us to provide that support and care that's needed early in the disease process so that you can maximize the quality of life as you are nearing the end. Most people think that DNR must be signed in order to use hospice, and that's not at all the case in most hospice agencies. We do encourage DNRs at some point within the care process, but it's the patient's choice and the patient's right to choose, not today, not right now. It's a decision made by the patient and the family. Another myth is that hospice is only for the dying patient. And hospice agencies do focus on, helping families to grieve and understanding the process. So there's so much more that we can offer before a patient gets to that dying part. As a professional team, hospice teams can educate and teach and help families to manage their grief and understand the process and to live life to the fullest. So it's certainly not just for dying patients. We do help to achieve quality of life. One of the others is that hospice is only for cancer patients. And we know, of course, that there are a number of different disease states that are appropriate for hospice, like HIV, kidney disease, heart disease, and Alzheimer's. One of the most important ones is that hospice is expensive. Many people don't recognize that hospice is a Medicare benefit. It's an entitlement. And I do believe that it's probably one of the most underutilized out there, but it's a very robust benefit that can benefit so many patients. And, it provides really essentially everything that's needed to support a patient's hospice diagnosis. And so in many instances, there's very little, if anything, out of the pockets of patients and their families who are utilizing hospice care. And so we could go on and talk about the various myths and facts about hospice, but we do want to share that all is not lost, that there are some positive things that are coming around the bend. We're not quite there yet as an industry. Equitable access to hospice care is not something that's going to happen overnight, but it is becoming a top priority. It's a business imperative. More and more, we're finding that providers are recognizing that delivery of great care doesn't necessarily start at bedside. It begins long before a hospice patient signs the consent to come on board with hospice. And organizations like the National Hospice and Palliative Care Organization has really laid a lot of the foundation for the work that we do in this industry. And they're consistently developing roadmaps and tools for hospice providers to engage with underserved communities in meaningful ways and effective ways that foster sustainable progress in the diversity and inclusion space. more and more hospice agencies are aligning their mission with the values that promote diversity and equity at end of life. So we're embracing that moving the needle requires that we look within our own organizations first and evaluate our own culture and establish alignment between who we are as an organization and what we want to be and who we want to be for patients and communities that we serve. And in order to provide culturally congruent care, we understand that we have to look at life and death through the lens of our patients, through the cultural lens of our patients. And so and realize that one size does not necessarily fit all. And so creating opportunities, we're working so hard to create opportunities to engage directly with members of underserved communities. And that means, having patients or having employees on our team who look like the patients that we're serving. And that allows us to go places that otherwise we wouldn't be able to go, facilitate conversations, build relationships, and provide the best quality care that we can. And so we're just looking forward to, what the future holds in this space. Thank you, Risa.
Thank you. I want to invite participants to submit any questions that you have. I do, Mary, you made mention of a DNR, and I just, to be sure everybody knows, you were talking about what's known as a do not resuscitate order, just in case any of our participants weren't familiar with that. But Jackie, we do have a question that says, if you are on hospice, can you go back to the hospital if you want to? And I know that doesn't have a absolutely clear answer, but it does speak to patient autonomy and choice. And I wonder if you would address that.
Sure. So in terms of going to the hospital, certainly a patient always has the right to seek hospital care, but it has a much more expanded answer. So, for example, our hospice happens to have 7 different care centers, and we do treat acute symptoms. So a patient may call 911 who's on our service, may end up in the emergency room, is quickly assessed, and we determine quickly that they really don't want aggressive ICU type care. They just want their symptoms treated so that they feel better. And so they end up landing in one of our care centers. And so, hospices are a little bit different. Some may have contracts with hospitals, and so they may end up in the hospital under a contract. But, basically patients always have the right to choose. We try to partner with the patient to try to figure out, what does symptom management look like? And if it can be done, in a quick stop to the emergency room and then back home, that's great. If it needs to be a stop in a care center or a stop in a place where we have a contract bed, we'll do that as well. It's all about, what is it that the patient wants? What is it that the patient and family decide?
Right. And thank you. Before we got that question, which was perfectly timed, I was thinking of asking you about, how do we ensure that we get those referrals when patients need, when the diagnosis is made that a palliative care referral might be made, or the hospice referral, because I do think there is that literacy issue in terms of what is available, but there also, I am imagining, within the minority groups, it is that issue of trust. It is that issue of, am I going to have something taken away from me? And I wonder how you address not only being timely once you get the referral, but sort of working to get people to your program as soon as possible when they would qualify for services.
If that's for me, Risa, I'm happy to answer. So first thing I talked about is creating awareness. That's not just with the community that you're talking about, whether it's minority or non-minority. It's creating awareness in a couple different places. One, it's with the physicians, with, partnering with physicians, making sure that, Mary talked so eloquently about some of these myths, making sure that we've clarified that with that particular group. And in where we serve, the physicians are a large portion of our referrals. The other portion are hospitals. So going into the hospital, spending time training the staff, breaking myths with them, making sure they understand the full breadth and service of what we do. And then going out into the community. Mary and Sandy talk so well about our partners. You know, the spiritual piece of hospice is so important. And many times we receive referrals from a hint from a pastor because we've done a good job going in there and educating. So it's not a one size fits all, it's multidimensional, and it really is about trying to figure out how we can connect with the community. And so once we create that awareness, and then finding out as leaders, where are there disparities in what we're trying to do to serve as a hospice. And for us, you know, we're in a 2-county area in South Florida. It's very different what it looks like in the town of Palm Beach to what it looks like in a town in Belle Glade, where it's a very underserved, very poor community. So it means doing different things and being comfortable with doing different things and hiring differently. So I would say the idea is you need to be flexible in how you do that to serve a minority group, whether it's Hispanic or Asian or Black or Creole.
Right. Or if we're talking about LGBTQ and others, however somebody is identifying and particular needs. And so, Sandy, there are 2 questions that I think you can address. The first one is asking whether there are materials in Chinese for children's and teens specifically that help the youngsters understand what's happening to a family member, whether that's part of the materials you have available.
For Chinese CACCC, we don't have specific material for children's, teens or children, because I would say almost all the family members were facing the children all speak English. But we do have a Chinese material from, particularly in Taiwan, they have many of the children's book talk about related topics. And maybe this, Kathy, maybe you can contact me after the meeting, maybe we can talk more details. So I would say if we want to talk about, particularly here, explain their own illness, we prefer have them to talk to their family, you know, parents or so from children point of view, because we need to hear from the children what they have in their mind about their illness, how they feel, what's the things that scare them the most. So heart to heart, actually, seriously, it really helped out. I just have my new staff join us, and she have her 2 children play the heart to heart. And she shared that she almost in tears. I just, kids actually knows a lot than we thought.
Right. Well, we have a kids path. We have a pediatric program, both for children who might be ill, and then also counseling for children who have a loved one. So we appreciate that. And also there was a question about your coalition, you know, outreach in other communities and how that's replicated. And I think I remember seeing on one of your slides that you really do have outreach throughout the country and make your resources available. And we'll be including that in an email that everybody will get. But tell us a little bit about your outreach.
Okay, the outreach, we started at California, Northern California, and then eventually we moved down to the Southern California. We provide the 30 hours training. We recruit potential volunteers. They don't have to, as a CACCC volunteers, they can be a church group. Then they'll be able to take what they learn and go back to their church, serve their people. Hospital and hospice, we also help different groups beyond California, particularly in New York. We did 2 or 3 different 30 hours training. and they start to function. And then we have a group of people to doing the work. Now, this is the only thing I need to appreciate the COVID bring us is because the virtual virtual classes, people from all over the countries globally, they come in here to learn. And then through us, you don't have to be so-called CACCC volunteer to do that. We have our partnership. They will sponsor us. We do the training for their volunteers. We also help them to do the recruitment. Actually, we also show them how to establish their local coalition themselves or extend the CACCC service to their side. Unfortunately, we don't have any other coalition to serve their population outside Chinese American. Yeah.
But you certainly are available, an available resource. And I would imagine even those who are, working with other minority groups could benefit greatly from the work that you've done and learning from you. We have a question that I can throw to all three of you, but it's really asking about the length of stay in hospice for our respective communities that we serve, and has it changed year to year? And certainly, I think we can make a broad statement that hospice is not utilized for as long as it could be. But Jackie, maybe you want to.
Sure. So interestingly enough, our average length of stay right now is just under 60 days. The benefit is for 180 days. We had, I've been with this hospice for just about 17 years. And yes, the length of stay was a lot longer, but a lot has changed in healthcare. And with that, the length of stay has gone down. And, I don't think it's just, even though we're working to try to get it, longer, there are other opposing forces right now in healthcare. So I'm curious to see what Sandy and Mary are seeing in their communities.
Yeah, Mary.
Yes, and I have to concur. Now, with ours, we operate two hospice agencies, two centers. One of them, our length of stay, we're just into our new fiscal year, is just over 114 days. And then we have another that's around 75 days average length of stay. But, like everybody else, we see patients coming later and later to hospice. One of the things that we're facing right now is patients are discharging from the hospital to hospice very late in the game. And so they really don't get a chance to benefit from the services that we can provide. And they pass away within just a few days. And so that has become, a point of contention for us. We're very concerned about that. And that forces us to accelerate our education process and the messaging that we're putting out into the community that, the earlier the better. So we're seeing some of the same things that other agencies are seeing throughout the country.
Right. Thank you. I know so often we have a certain population on our census that have a longer length of stay, but then we have such a large percentage who die within that first week of coming onto services. And Sandy, I wonder if similar pattern. So it really seems to be a nationwide. And we know that it's tracked not just locally, organizationally, but state and then nationally.
Yeah, and unfortunately, I just have a long talk with one of our volunteers, also serve at one of the hospice here. She mentioned to me the new number here for the Chinese patient in their aging. They are very large agency. They say it's still under 30 days. So that says a lot. And I cannot agree more with Mary. The education is the key. Even it looked like we failed to improve the number of days of stay through our community education, but I truly don't believe so. I think it takes time and take more conversation, because the decision maker a lot of time by then is not by the patient self. Majority is by family member. Even if I'm dying, my children insist not to send me to hospice, but insist want to treat me and cure me. Normally, Chinese, you all heard that we are a unit, right? Family, it's not individual. So I want my children to be happy. I just go along, even I suffer, I don't want that. So that's the cultural things. We cannot expect the thousands years culture to be changed through this 100 years, right? So I think we're in the right direction. Another tips for everybody, since we all health professional here, I can share one little tips. Because as Chinese, particularly if you are a Buddhist, most people, I say 90% or probably even 100%, we want to die at home. A lot of Chinese patients, they don't know we have such wonderful service called hospice, right? You can choose to die at home. And all we know, but we think it's very expensive, like Mary talking about the myth. So we have a lot of work to do, let people know if you choose to die at home, hospice probably is the best choice. Even you don't want to die, but if the day comes. So we need to have this kind of program to let people understand we're not to sell you anything. Coalition play the best way because we are not any, we don't represent any of hospice. I myself never been a hospice nurse. So we're mutual. So we just know a lot of things about end of life, about hospice. So this is the option you have. And here's education I provide you. So we have many of my people we serve already complete advanced healthcare directive. They have a statement say that I want to die at home and my request. So I really think it's the power is education. Doesn't matter you're Chinese or Hispanic or anybody, okay? We all don't want to die, but we all want to die well, right? And that's a choice there, so.
Thank you. And so Mary, I'm thinking about just to talk a little bit about palliative care, recognizing that for some people, that is where they might enter one of our organizations for services, and recognizing that somebody much earlier in an illness may benefit from the services of palliative, and through your outreach, how we go about sharing information about that service that might help us build the trust and break down some of the myths, and then move to hospice if and when it's appropriate.
Absolutely. Palliative care presents a phenomenal opportunity for us to engage patients early in the process, in the disease process. And so, they are able to come on services. I think one of the barriers that I see with hospice, to hospice, is that patients don't necessarily want to discontinue treatments. There's that risk reluctance. There's a struggle between, I want hospice, but I don't want to give up my treatment. I still want to pursue every aggressive measure that I can. And so palliative offers the opportunity for patients and families to get support in the home while still undergoing any aggressive treatments and interventions that they want. When we engage on the palliative side, we're able to have those conversations about goals of care and what patients hope to, what they aspire to or aspire for, as we are working through this process. And we can, assist them in getting their advanced care directives into place and making their plans, empowering them to make their own decisions early on before it becomes so dire and someone else is making decisions for them. And so for our agency, for AuthoriCare, for example, palliative care has really been an asset in, oftentimes patients will say, no, I don't want hospice. Well, we can default to palliative care and have those conversations, educate patients on the disease process and the disease state, what the trajectory of the disease may look like. And by the time that the disease advances and they are more appropriate for hospice, patients have already had those conversations. They're already educated on, what to expect, and it makes for a far easier transition from palliative care to hospice. And so with our agency, we have an extremely robust palliative care program, which is very telling. It is an avenue to access. It really is an avenue to access for us. And so we're just grateful for that. And it serves a phenomenal purpose in helping to move patients along that continuum.
So Jackie, we are just about at the end of our time, but I wonder if you could leave us with, as we really do focus on the celebration of diversity, not only in those who provide hospice and palliative, but who receive the services. And so if you were to say to us, you know, what is our hopeful sign that we are working towards and striving towards, what would you leave us with?
I am honored to leave you with a message of there is a community of hospice nationally throughout the world that do work consistently to create this awareness. We are diligent in trying to, break the barriers. I mean, let's be real, Mary, you touched on it. Sometimes it's even clinicians themselves. We've got to break the barriers on how they're treating the customer, and sometimes it's the language, it's more concrete, but we have a whole, as Sandy so wonderfully said, it's a coalition, it's a group between what Medicare is trying to do, what the NHPCO, National Hospice and Palliative Care, is trying to do, what the government is trying to do to really create awareness and take away the disparities. And then at the local community level, hospices are really good at cultivating the partnerships that I talked about. Mary talked about it. Sandy gave us examples. I mean, we are diligent in creating these partnerships so that we can better serve you, the community that's out there, regardless of what, nationality, culture, religion, color of your skin, it doesn't matter. We are teaching people to be honest in communication. Sandy, you touched on it so poignantly. Patients want honesty near the end of life. And these are trainings that we're doing with the community, with our own internal staff. How do you have these difficult conversations, and how do you do it openly, compassionately, honestly? And then lastly it is just lots of training, education, awareness, goes right back. It's a whole cycle, and we're committed to that. And for us in hospice, it's a passion. I mean, it's something that we live it every day. And you've heard from two very well, Risa as well, all of us, it's something within our core. We want people to take advantage of this benefit that you don't have to pay millions of dollars for. So I hope I did it justice.
No, that was beautiful. And I will say thank you to the three of you, not only for your expertise, which is tremendous, but more so for your passion and your empathy and the work that you do every day for every person that you come in contact with. And thank you to our participants for being a part of our conversation. I want to invite everyone to look for an email you will get tomorrow. It is going to have access to the recording from today, but also many, many resources that speak to this issue of celebrating diversity. So look for that email tomorrow. And then look ahead on December 1st. We are going to be having a conversation about healing at the holidays. And it will be addressing the needs of adults and children. So we hope that you will look for information about that and register to join us for that conversation, because it's so important this time of the year to so many. And with that, because it is National Hospice and Palliative Care Month, it seemed appropriate to close with a quote from the founder of the modern hospice movement, Dame Cicely Saunders. And what she tells us is that hospice, you matter. You matter because you are you, and you matter until the last moment of your life. We will do all to help you die peacefully, but also to live until you die. And with that, I will say thank you. Thank you for joining us. Be safe, and we look forward to you joining us in the future for another webinar. Thank you.